as always, we first start with an icebreaker question while we wait for people to trickle in. And the question of today is one that I configured together with ChatGPT. And the question is, if animals could be trained as healthcare providers, given the shortages that we are currently facing, which animal do you think would be the best at patient care and why? So I created 3 animals. All 3 are my favorite ones in one way or another. So I hijacked it a little bit. But so the first one is an octopus for the reasons that you see here. The second one is a penguin, mostly because it's extremely cute, and I think they would be thriving at a child department. And then the third one is a cheetah, which might be interesting for the ER probably. So looking at these 3 animals, Adrienne, which one do you think would be thriving most at Ryse Health, and why do you think that's the case?
I think probably the octopus, because you're doing multiple things at one time and wearing a lot of hats, or I don't know if tentacles have hats, but yeah, I think the octopus makes sense.
All right. What do you think, Sarah?
I like the octopus too, but you'd have to make sure each of those hands is knowing what the other hand is doing, right? And being well connected. So that would be my one caveat on the octopus. I like to move fast, and so a cheetah could be great, but there is that drawback of going too fast. So I don't know if you've created the perfect animal, Rick. Maybe AI will have to iterate some more.
What do you think if the ones not listed, do you have an animal in mind? I was thinking about a dog, but I'm not sure if that's a good animal either. So if you have suggestions for the AI, feel free to let.
I'll work on it.
Perfect. All right, cool. I enabled the chat, so everyone feel free to use the chat. Thomas is not joining us this time, so it's just the 3 of us, which is cozy and fun. Before we jump in, obviously, thank you, Sarah and Adrienne, for joining. I know that you are busy, especially given the end of the year stretch. So thank you for finding 60 minutes in your calendar to meet and talk about care flow improvements. Also, thank you for the 250 people that signed up. We are now a community of 4,000 people, growing rapidly. This session is as always recorded, and we will send the recording to everyone who signed up. And we'll do a Q&A at the end. So feel free to, during the chat, ask questions in the Q&A, or also afterwards, we will have some time to ask elaborate questions. And obviously, you can also use the chat to talk or discuss the points that Sarah or Adrienne touch upon, or maybe what you want to drive further on. And talking about AI, we have 2 AI assistants helping taking notes. So thank you for joining us as well. So I will not do proper introductions, but feel free to introduce you while you answer a question if you think that it's relevant. The first question that I have is one for Adrienne. So as you know, the panel of today will be about continuous improvement. So once you have your V1 care flow established, how do you go from a V1 to a V2, and how do you enable continuous improvement in your organization? And a few weeks back, we had a session around care flow adoptions with people from One Medical and Time Care. And there we agreed that the biggest problem with care flow is that it takes months before you see the outcomes impact. For example, if you focus on reduction in ER admissions, which makes it challenging to decide when you want to iterate or improve your care flow. So my question to you is, so based on your experience, when is the right time to go from a V1 to a V2 or beyond?
Yeah, I think when you have long-term outcomes that you're trying to improve on, that makes it hard because you can't wait 6 months to see if ER admissions are really down. I think 2 things you have to look at is iterating on the process and the impact to the team workflows, because they are going to give you real-time information. Is this working or not? Is this more burdensome or helpful than their status quo prior to the technology change? And so real-time feedback from the team on, is it improving their efficiency, should be a huge piece of if you're ready for V1 or V2. And that also takes time because there's the initial adoption where everything seems harder no matter what the tool is. So you have to give the team time to train and get used to the tool. And then once they feel a little bit more comfortable and they actually become more proficient using it, then you'll have a real test of, is it improving their workflows and efficiencies. I think the other piece is, what are the leading indicators that are directly tied to reducing ER admissions? So those are the more short-term metrics that you should be looking at, not just the long-term ER admissions, but the daily management metrics. Are the team members following up and processing any ER admission ping data, or what are the precursors to ER admissions, their number of urgent care visits or number of phone calls for triage to talk with the nurse that usually lead up to a potential ER admission. So I think having leading indicators that can give you a signal that a high ER admission is likely because these things are happening in the short term will also help you think through maybe having a shorter term V2 plan, because you can reliably predict that ER admissions in 6 months are going to be high because these leading indicators are seeing an increase as well.
Yeah, I mean, we talked, you also mentioned that there should be some non-negotiables. So if this happens, we need to change the process. Can you elaborate a little bit on what you meant with that?
Yeah, I think when we talk about a V2, there should be some established criteria around what we say. If this happens, then V2 is not an option because we need to stop the line and work on these issues to the point when we talk about the impact to the team. If it's making things demonstrably worse for the care team, then that's a non-negotiable. If the team is screaming bloody murder, like that this can't go on because this is not sustainable or scalable beyond this V1, that's a huge red flag that we need to pause and go back to the drawing board before we even contemplate a V2. And so coming up with your leadership team and the design team around what are those non-negotiables, not only from the end user, but also from the team that's building it, because there's resource constraints. And so, everybody's like, oh, this is great. It is going to take X amount of dollars in sprints to make this enterprise-wide. That may not be a go-time decision because of the budget. And so defining those non-negotiables early on is key as well.
Yep. Do you have like a number of non-negotiables that you have? Is it like a list of 5? Is it 10? Is it 20? Or is it dependent on how?
I usually stick with 3 to 5 as a comfortable number. Usually 3 to 5 is a comfortable number. It's not too big, and everybody can keep those top of mind as they're going through the process. So everybody can have a quick rubric in their mind around what those three to 5 things are. But if it goes beyond that, it becomes unwieldy. And so I think 3 to 5 is a good amount of non-negotiables that is everyone in the project team can agree on. And you also have to come up with, like, do all need to be true, or is just one of these is true, then it stops the line. So it's also not just that you have 3 things, but do all three things have to be true, or one of the 3 is enough to stop the line? Yeah,
okay, that makes sense. And seems like I'm struggling a little bit with my internet connection, so sorry for that. So maybe, Sarah, we will definitely touch upon feedback because I know Crossover is very focused on feedback and getting provider feedback. But before we do that, do you have anything to add about like when this Crossover Health, for example, moves from a V1 to a V2? Do you have a structured framework or timelines for that, or how do you think about that in your role?
Yeah, well, I think a lot of the things we've covered, but it is that kind of, are we meeting our goals, and are our benchmarks in place, and are we making progress there? And so I think that is a mark of an organization that's on that V1 to V2 journey in a healthy way, being really clear and transparent about that process, and what you're marking as setting out to do, and the progress you're making are all really important. So yeah.
And so Adrienne's point, feedback is one of the most important ones. So you have clinical feedback, which we'll focus on first, and then we will get to patient feedback afterwards. But with regards to collecting feedback from clinicians, Sarah, Can you explain a little bit more on when you collect provider feedback? Is it immediately one day after the launch? Is it 1 week later? Is it 2 months? And then once you collect these feedback, how do you collect it? Is it via a Google form? Is it inside your EHR? Like how do we, or how can we streamline that process?
Mhm. Well, I would say that we have a lot of clinicians who are very happy to give us feedback all the time. That's part of our culture. And so I think that actually helping them figure out when and how best to give feedback, especially when you're doing these versionings, right? And you're working through thorny problems, that feedback all the time isn't always the most helpful as you're moving through that process. So we've employed a lot of different ways to get that feedback. We do provider kind of like surveying through Google Forms. We do versions of like office hours and kind of open forums to talk. I think those are the two main ways we do it. And then of course, people are always reaching out and willing to share their experience, which is so great. And I do think that that's part of what I love about where I work at Crossover Health is that participation. Everyone has a voice, and it's really one of our core values to be curious. And I think when we can create situations where curiosity is accepted and welcome, we can get a lot of great feedback because people feel, welcome to give that feedback, but also just welcome to ask questions like, why are we doing it this way? What if we did it this way? And so that's really helped us as we move through versions of things and get that feedback.
And what's something that you did before when it comes to provider feedback that you're not doing anymore, that didn't yield the results that you were hoping for and that you just stepped away from?
Yeah. I would say that in some of the kinds of questions we ask, very specifically on feedback forms, where it's just kind of a yes or no answer or a white or black answer, right? Where it's dichotomous in that way. We're trying to do less of that because it's always about the context and it's always about the nuance, it feels like. And so trying to get at that additional context and nuance is really what helps us really make those changes that are going to be significant as we work to improve.
Yeah. Okay. And then Adrienne, so when we talked, you also talked a lot about provider feedback and getting that feedback. Do you have a same approach as Crossover? So the combination of Google Forms with some office hours, or is there something else that you also do that is impactful for your organization?
Yeah, I think similar, we may have Google Form surveys. So we have a baseline and similar questions, but I think also having specific pre-scheduled retro debrief meetings around the process on a regular cadence is also helpful because you tend to get more candid feedback in those discussions, and having them be small groups, they can't be too large, but then some people won't feel comfortable at a larger group, and also paying attention to what team members are a part of that feedback group. People tend to be more candid when it's like with similar cohort. If you have a team of nurses, team of health coaches, or different people, they, have similar struggles and similar concerns. And so they'll, feed off each other and provide additional details. But if you're in a larger room and there's a doctor and then an MA, the MA may not feel as comfortable voicing their concerns with the feedback, given the power dynamics with their provider in the room. So also thinking about the audience and the cohort on the attendee list for those retro meetings is helpful.
Yeah. Okay. And when do you send out the Google Form? So let's say that we go live with an ER admission care flow tomorrow. When do you want to get provider feedback? Is it on Monday, or is it already on Friday, or when would you send out that Google Form?
I think at least a week typically, because the first day, there's usually not going to be anything positive off the jump because it's already a new process in the workday. So most of your feedback's going to be how hard it was to integrate this into the first day, not about the actual process or tech itself. So giving the team a week to like sit with the process a little bit, but also having a kind of another touch point like a month in, because they've settled into the process more, and seeing what's the difference between that week 1 feedback and the 1 month feedback is helpful.
Yeah. And then, so Sarah, you mentioned that you have a culture of giving feedback and probably also receiving feedback. Is there anything specifically that you did or do inside Crossover to incentivize this feedback, or is it really just a cultural thing?
I think it's really just a cultural thing. I think we've worked hard to foster that by making sure that those lines of communication are open and that we have those forums for people. And we talk a lot about what it means to be curious and to ask questions. And we spend a lot of time working to, empower the people doing the work to inform the work and help change the work. And so I think that those things together help that happen.
And did any of you ever experiment with like giving real incentives to providers to give feedback? For example, giving them a 1 month Netflix subscription or something silly like that? Or is it really just always coming from the clinician itself to provide that feedback?
We've never done anything external, like a bonus kind of thanks for your feedback. So that's not a tactic we've ever used. It's usually just coming from their participation in the process.
That's good to know. That's definitely signaling that you have the right culture in place. And then I assume the way that you create a culture like that is also to make sure that whenever someone gives feedback, it also is acted upon. So how do you prioritize, maybe first to Sarah, how do you prioritize and implement the feedback that you receive from your providers? Because I assume if you have a Google Drive or a Google form, you send out, you get a lot of responses given that you have a culture of feedback. So you need to go through the list. Who is going through the list and how will you prioritize and with who will you prioritize?
Yeah, it takes a lot of time to go through that feedback, right? And yes, to collate all of that, to read through all of the forums, all of the comments, and to try, place them in buckets. Like, what are the main themes that we're seeing? What's similar? What, is a function of a process? What is a function of technology? What is a function of other things going on, right? It's good to kind of start to separate out, right? I think a lot of times our work's a lot like spaghetti. It's not like a waffle. It's all mixed in there together. And so you have to figure out what strand you're actually pulling on. And that's what we attempt to do with the feedback, and then try to be transparent, once we've kind of assessed the feedback, to turn back to the group who gave us that feedback and share what we found. And so that's part of what we do, is we usually share what we found, and we're really transparent about that. We don't always link it to a person, right? But we say, these are the things we're hearing, the kinds of comments we received, the kind of feedback we're receiving, so that it can also, resonate then with those who were giving feedback. Are they resonating again, saying, yes, that is what we were trying to say? Have we captured, did we take from the feedback what they were intending and what the group's coming around? And so some of that strategy is employed in our kind of moving through that feedback, so that we can really sit down and say, okay, what's next based on what we've learned?
And how long does it normally take? So let's say that I give you feedback on a care flow today. How long will it take you to get back to me? Like, when do I as a clinician get a response on the feedback that I gave?
Yeah, great question. I think it depends on the project. I'm not trying to dodge the question, but I think it depends on the project, and what kind of care flow is in place, and where in that care flow kind of versioning where we are, right? And so let's say it's the example of like, hey, it's been 1 week, since a new care flow went into effect, and now we're assessing that. We're going to assess that feedback as fast as possible, right? We're going to take several people and put them on that. We're all going to meet and go through it so we can get back to the clinicians, because I do think it's kind of like a snowball, right? As it gains speed and snow, it's going to get more and more powerful. So those early moments are really important to kind of capture the attention of the whole group, and to act smartly and quickly to surface what we're learning, and get back to those people who are helping us learn.
Yeah, that makes a lot of sense. Adrienne, is it the same way that you prioritize feedback? Is it also like looking at it and then putting it in buckets, and or do you have any other frameworks that you use within Ryse Health that you think is valuable when it comes to collecting and acting upon feedback giving or getting from clinicians?
Yeah, I think it's definitely bucketing into key themes, what you hear. You can have hypotheses, but you won't know until you get the feedback to know kind of what buckets there are, because you may think it's focused on one thing. You're like, oh, this came out of left field. I didn't know this was going to be a theme coming back from the team on the workflows. And so once you have those buckets and you're thinking about like, these are the buckets for the themes and what's working well and what's not. And so you can highlight both, because I think a lot of people, if you just focus on what's not working well, it can be deflating for the team that designed and helped build it and bring it to fruition. So they want to see what positive is actually happening with the change in the new technology. But on the what's working well, when you think about the buckets and what to prioritize, it's like, what is the biggest pain point for the team in the short term is probably what you want to prioritize, and where can you get some quick wins? Because if everything is tied to a very long process of a V2, that'll also be frustrating for the end users. They're like, all these things can't be fixed until V2, and they're going to be like, ugh, then what's the point? And so identifying what are the quick wins from some of that feedback that you can quickly iterate on is probably where you want to think about prioritizing your initial work. So the team, one, feels heard, and they also feel like the project team is taking their feedback seriously.
Yeah, and then a question from the audience, maybe for you, Sarah. So you have these improvements. So I, as a provider, give you feedback, and then sometimes it also means that your product team needs to build new features, or that you need at least spend some time on it. So which obviously comes with a cost and an opportunity cost as well. Do you need to sell these improvements to your finance team or your leadership team? And if so, how do you manage that? Is it really selling all the improvements, or is it only selling the big improvements that really come with a big cost?
The way in which I work with our product team, so I, as the program manager for population health, I'm kind of over both quality and population health within our organization. And I actually sit within in the medical group. I'm a nurse by training, and that's my background. And so I have cross-functional partners in other places in the organization. And one of the things that I do is I sit as close as I can to my product partners. And we meet a lot. We're in a lot of the same meetings. I bring them along to a lot of conversations and work to help them understand really where we're at with what we're needing. And so that when we get to a place where we're implementing something, right, they understand the work just as well as the care team members do it by that point. Like, that's really what I see my job is bringing them along in that, so that then when we're asking them to iterate or change, they have such a deep understanding that that's not a conversation I'm ever having alone with finance, right? It's almost coming from the product side. They're able to not only set up their whole structure, knowing what we might have to iterate on, but then they're also able to join me in that partnership as we say, hey, for this to work, we're really going to need this. And they're able to say that because they know it too.
Yeah. Okay. And then last question on the feedback, because it's becoming a rabbit hole. So sorry for that. But Adrienne, so we talked a lot about clinician feedback. Do you also incorporate patient feedback to drive care flow iterations? And if so, how do you do that?
Yeah, I think it depends on the intervention or the new tech that we're implementing, where possible, and it directly interfaces with the patient. We definitely want to solicit that, but it depends on when you get patient's feedback, because it may not be something that a patient interacts with that frequently. If the patient's just coming in like for annual visits once a year, and you're only running this for a couple of months, you may not get a high enough end to make that feedback valuable, because not enough patients have come in to experience that interface. But where there are multiple patient touch points, I think it's definitely valuable to get that patient feedback, since it's something that they interact with regularly with the healthcare system.
Yeah, that makes sense. Sarah, do you have anything specific in place with regards to patient feedback to drive iterations of care flows at Crossover?
We do have some functionality in our patient facing platform for them to give feedback just mainly on their experience. There are care surveys that I feel like we get all sorts of information about all sorts of different things on, right? But we don't have, I would say, specific formal ways to do that for a lot of our care flows.
Yeah, that's so we also had the State of Care Ops survey, and that's also what we found. So it's not untypical. So Adrienne, you mentioned earlier that you need to have measures of success signed off so you can judge the impact of the care flow, which then informs the iterations. And besides tracking these measures, you also do these care flow audits. So the retros that you mentioned and the debriefs. Can you explain a little bit more to the audience how you run these care flow audits and what you want to get out of these?
Yeah, usually in those care flow audits, one, they're scheduled, especially with the care team in advance, because patient care is always a priority. So if you want to make sure the care team members are actually in the room to get their feedback, you have to be very proactive in getting on their schedule so there's not any conflicting patient care needs. I think a big piece of it is pressure testing the feedback. When people provide things that they feel aren't working well, like, is that an individual preference or is that a systemic issue that everyone on the team is experiencing? Because a lot of times people may mention something, but that's just because that's not how they work or they're used to it in a certain way, but it's not a systemic issue that is a problem for the larger group. So I think having probing questions around, is that something that's unique to you or is the whole team experiencing this issue with the new tech that it's been implemented? I think another piece is having a round robin where every individual gets to speak. So it feels like not one person's voice is overshadowing the group, because there will be one or two people who are more vocal than others, but definitely calling out individuals and allowing them to speak in the meeting. So everyone has a voice, and maybe waiting till the end for the more vocal people to speak, because they're going to speak up and take a long time anyway, I think allows it. So if you let the people who are a little bit shyer earlier on, they'll at least have that opportunity and feel heard without the louder people kind of overshadowing them. And I think another piece is having individual follow-up conversations based on specific things that were mentioned. And so you may not want to go down a rabbit hole in one specific thing in that forum, but following up, say, hey, you mentioned something interesting in the debrief or in the retro around this new process. Would love to get your thoughts and get more details so I can understand what you were experiencing. I think those are also helpful because, of course, people are a lot more candid in one-on-one situations than in the group setting.
And so is the care flow audit, is it always specific to one care flow? Is it just like you look every month at the care flows that you have and you look at the feedback and then you go over the feedback?
Depends on what care flow changes were implemented, if multiple were being changed at the same time, just soliciting different feedback, but also being direct and asking, okay, care flow 1, how is that working? How is it not? Care flow 2, because if you just ask generically, people will give you like, everything's fine or everything is horrible. So you have to be very specific because 2 of those things may be great and only one of them is problematic. So you have to ask about each individual care flow.
And then before jumping to Sarah, is then the meeting, is it then structured, like how big is the meeting group? Is it then a group with nurses, and is it then a group with doctors, and is it then a group with social workers, or how do we need to see it, or is it a mix of everyone?
Were you asking Sarah, Rick, or was that for me?
Yeah, sorry, that was for you, Adrienne. Yeah.
I'm sorry, could you restate it? I thought you said Sarah, so I thought it was for
no worries. So if you do the care flow audit, is it who's in the group and how big is the group?
Usually I think of a group of 10, at most 12, but the smaller the better. One, so everybody has a chance to speak up and it's not too unwieldy. Usually about 10 or so. And if you need to split it up, it's even better. But I know like time is of the essence, and so sometimes you have to have a group of 10 or 12 because of schedules. But typically like 5 or 6 is really great because you can have like really good robust discussions and get a lot of details. But the larger your group, the less details you'll get, and you'll have to ask follow-up questions after the fact to get more insight.
Yep. Okay. And then Sarah, do you also have something at Crossover Health that is related to the care flow audit, or how do you do that internally as well?
Yeah, we also do those kinds of debriefs, and they're usually cross-functional, and like Adrienne said, we attempt to go small as well, but we found specifically even with our clinical team members, it is really good to have the whole group there, the team that's working on the care flow. We usually kind of start with a care flow with a certain team, kind of like either a pilot kind of setup or a proof of concept kind of place, where we're at with a group of people. And so they've come together even as a group to own it. And so they're pretty candid with one another and with us, but we've also found that it can be helpful. So like, yes, keeping it small is really important for people to talk, but it can also be really helpful to have other cross-functional partners like our product partners, right? Even sit in and listen to some of those conversations. And so if we're able to do both things, keep it small and have some listeners, that can be really fruitful. So people can, the bridges can be built across the different places. Yeah.
Yep, that makes a lot of sense. And then so let's say that it's clear that we want to move towards the next iteration of the care flow. How do you continue, and this is a question for Sarah, by the way, how do you continue to motivate your clinicians to get through these changes? Because I'm a nurse myself. I know my nurses friends, they like stability in some ways or another, and they definitely don't like people telling them what they need to do as of Monday, let's say. So how do you motivate them to continuously improve and to continuously adopt the new processes that you've put in place?
Yeah. Man, change is hard. Change is hard. Maybe understatement of the century. We all know that. I mean, this is healthcare. It's change all the time. And so it's kind of a non-negotiable to some degree in coming into healthcare, is you have to have that flexible mindset, right? That things are going to change and you're going to have to adapt and adopt. And so I think in my work, I think being a nurse has helped me a lot in doing this, and in being able to say, I get it and I know it, I feel it, just like they feel it. But I also think there's a degree to which just that pure acknowledgement of what is hard and that the change is hard, and the fact that we're asking people to be different again can be a big ask. I think that human element for our coworkers goes a long way. And even just kind of acknowledging where people are at and what's happening. That doesn't mean we get to stay there. It means we get to continue to move on and iterate and make the change. And that's not always easy, but that's also work. That's why we call it work. There's an element of hardness about it, right? It isn't always easy, but this is what we've signed up to do. And so yeah, it's not always easy to motivate, but it is the task ahead of us. And I take that motivation part pretty seriously and spend a lot of time thinking about that and cultivating relationships for that reason, because it's such a huge piece for us as a team to get right as we move forward.
And so Adrienne, let's say that we need to go to a V2, and then you have some things that change in the program, some if this and that logic that might change. How do you communicate that to your team? Is there like an internal wiki or something, or is it an email that you send out to the clinicians like, as of January we changed this process to this, or how do you communicate that to get that change adopted as well?
Typically I'm more of a fan of meetings. I know the healthcare is very focused on meetings, but to make sure everyone's aligned and is hearing the same things, because even when you send out an email or a presentation, people's takeaways from those materials are varied. And so those are all great to do as a follow-up to the actual meeting, but believing having a meeting with all the people who will be end users of the new product to go over and demo it, and also it's like very focused on why we created this or why we're implementing this, and what is the desired goal, and also to solicit what are people's initial concerns with this, so we know that up front, and then focus on, well, we're trying this. This is not the final end all be all, but this is the timeline and the process, and also laying out when and how we're going to be asking for their feedback. I think that takes some of the bite out of implementing something new, because we're telling you that this is not the end of the conversation, it's just the beginning. But I like to do that in a meeting. And so to also give everybody kind of like, any questions, any concerns, any rumors, all the above, speak now, forever hold your peace. But we all know there's the meeting after the meeting, but having that forum, I think, kind of squelches some of the side talk about the process, because everybody was given the opportunity. And to also ask questions. It's hard to field questions when they're just coming at you in a Slack or in a email. But if everybody's in the room, we can kind of answer those questions, and it's helpful for other team members to hear the answers there.
Do you embrace a similar approach, Sarah, or how is it done at Crossover?
Yeah, I would say we embrace a similar approach. And I love what you said, Adrienne, about like being in a room together, whether that's a virtual room or a real room, but really having that chance to have everyone hear the same thing and have the benefit of others' questions. I think it's kind of basic, but it's fundamental, really fundamental, and important to do, to get people off on the same foot together. And of course, we know it takes a lot of times of hearing things, right? Again, it's like that first pass of things will bring up one level of things, and then they'll go back and think about it more, and you'll hear more. And so kind of planning for, even if it's like a kickoff kind of call, like what's that next call? When are we going to have that? When's that next benchmark in the process for people to kind of consume the information again, and have an opportunity to give feedback?
Yeah, that makes sense. And then so tied to the feedback, you mentioned during prep that you're a big fan of the people process technology framework. When we talked to Jessica Green last time from TimeCare, she also mentioned that to get to Careflow adoption, the product needs to inform the Careflow. So we need the engineering team, we need the product team to also be on board on the changes that we want to do. So let's say that we received the feedback in our Google form and we did the Careflow audit. How and when will product be involved? Is it before the feedback? Is it after the feedback? Is it during the feedback? And how do you move from there with the product and engineering team?
Yeah, I think it's helpful to have the product and engineering team as a part of the feedback. So we have representatives in those retro debrief meetings, because the way I hear something, it will be very different than the engineer or product manager would hear it. When they hear a person's issue, they're thinking, oh, this feature needs to do this thing, or we need to fix that bug. I'm hearing like their pain point and thinking of the workflow and handoffs to the team. And so I feel like engineering product teams need to be a part of all those sessions, or some having a representative there, because they hear things a little bit differently. And then the project manager and the product manager and engineer can have their own mini retros as a project team to say, okay, what did you hear? And this is what I heard. And so how do we translate that into a plan for V2? So I definitely have worked with a lot of great engineering and product teams where I think they thought I was going to come back to them with the stuff. I'm like, no, you're with me the whole way. You're going to be in the meetings with me. You need to block your calendar. And so that was new for some people. I'm no, like we're in lockstep this whole time. Once you hand this off, it doesn't mean I'll go and then I'll come back to you in a few weeks. Like you're with me the whole way. And I think they learn a lot, and it also makes the V2 version so much better. And the team feels it's harder for the team to be angry at the engineers because you see them in the meetings. It's not just some faceless department that put something together that you didn't like, because now you know Rick and he helped build it, and you can't bad talk it because you actually like Rick and you talk to him in several debriefs. So I like including them in the meetings. Not to pick on
I
you,
love
Rick.
that. That's good. Because I see a lot of organizations where they indeed gather feedback, and then it's a clinical ops person that like buckets it, and then they give it to the product team, and then the product team misinterpret it, and then they build something that makes not a lot of sense, and then it's like friction all over the place. Sarah, I also know that you're like the glue between ops, clinical, product, engineering. So you're definitely doing the care ops role. Let's say, how do you approach your product and engineering team when it comes to moving to iterations of care flows?
Well, like Adrienne, I tried to avoid a terrible game of telephone, right? Where we're just passing information up and down a line. It's not effective. And, I think that I really lead with, we're all motivated by the same why we're working on a project, right? The why is the same for all of us. And so making sure that we're clear on that and the way in which what we're doing matters for the member or our patient is really important for me. I feel like in part of my translation role for all these different areas, the translation that I do is to make sure that that's really clear. So we can invite other kinds of creative thinking, right? Other kinds of creative solutions. But we're all trying to answer that same question instead of, thinking we're answering the same question because it's been passed down or back, but really being solid on that question. So I spend a lot of time with my different partners, and maybe this is again, like my background as a nurse, but I'm like, not that product is a patient to me, but like, that's how I treat it. Like, these are the people that I'm working with. These are the people that I'm caring for. We're trying to get to this outcome for our patients, but how do I help the people in front of me that I'm working with get us there for that patient? Because they don't have the benefit, of seeing each one of those patients in that exam room every day. So I take that translation piece seriously.
Awesome. So what we learned previously in the previous panel was also that you never deploy like a care flow all over the place, like full organization wide, because I don't need to explain why, but it leads to some problems. Let's say that we have a V2 established. Will you then go back to the initial sandbox practice where you implement the V1, or how do you then pick the locations to go to a V2?
Usually,
Sarah,
usually we do go back to that first group that may have helped us. They have the benefit of being a little bit further along in the journey, right? And so usually they're able to help support us as we're moving into another iteration differently than other parts of our organization. So that's usually what we do. Though I think sometimes we have gone to other places if there's a really unique part of the care flow that's kind of showing us its face for the first time, like a part that isn't working. Maybe that's unique to a population that is specific to a certain location, or there's some sort of uniqueness there that we kind of have to dig in around. So, but mainly it's usually going back.
Yeah, that makes sense. Is it the same for you, Adrienne? Given that you're more remote first, so it's also just picking the specific locations that you want to, or the states that you want to target, or how do you approach that and the changes and implementation?
Yeah, definitely going back with the initial group that provided the feedback, so they can see how the improvements, how the V2 is actually iterating and improving on their experience, and that gets them more excited about it. I think there can also be a good reason for, if you're looking at a different group, or the kind of like in a phase 2, the next group, what's their experience of V2 being their version 1, and kind of getting that perspective, I think is also helpful. Because when they usually, oh, this V2, it's great. And it's like, yeah, it's great because this initial group provided all this feedback. So thank them, because they made your experience off the jump like amazing. So I think there's also having a second group have their V2 be their initial experience of it is also validating that the process is working.
Yep. And then so one of the reasons, so when I talk to operators and I ask them about continuous improvement, one of the reasons that they are afraid of going through is just change management, as Sarah said, is extremely hard, and they don't have the appetite to do it again. So it's like we have a V1, it's working-ish, and maybe we can improve, but we don't do it because I'm afraid of change management. So maybe, Adrienne, can you share a specific instance where you transitioned from like a V1 to a V2, where you significantly improved the outcomes, which can be patient outcomes or provider outcomes, and where you really sell the idea of continuous improvement to the people listening in?
Yeah, I think it was a big example is redoing our whole scheduling system for my previous organization in the midst of COVID, because of course we're used to everyone going to a specific location, and then COVID turned that on its head where people could service various locations remotely, and you had to think about where is the doctor, remote or in practice? Where is the patient, remote or in practice? And where is a team member, remote or in a different practice? So the permutations of the complexity were exponential out the gate, and our scheduling system was based on everyone's in the same practice at the same time on this day. And there's no need to think about remote because that doesn't exist. And so we had to redesign our whole scheduling system. And of course, we had lofty ideas. I'm like, it needs to do all this. And then, of course, we were brought back to reality by our engineering product team. They're like, yeah, that's going to take like 2 years. So what do you want done in the next 3 months? And we're like, oh, okay. Didn't realize it took all that. But we got to a good place where we were able to define like who's remote in person for the team as well as for the patient, and have great visibility into that in a way that wasn't overwhelming for the team on the schedule. And there was a lot of workarounds that team members had did in the short term when COVID first hit that just made the schedule unreadable. People were putting their own blocks, and it was like 3 or 4 like blocks on the schedule that were all happening at the same time, but they said different pieces of information because there was no other way for the team to know this person is physically not here. Please do not schedule them at this clinic. They're technically here. And so our ultimate goal was like, there should be no extra blocks. No one should have to put a block to denote anything. It should be visible in some other discrete form of information and data. And so that was the V1 that we wanted to get to. There were plenty of other things we wanted to fix, but that was the initial problem we were trying to solve. And it was a huge win for the team and for the managers to not have to manage those additional blocks on the schedule. So it was actually clear and easy to read. And so when you have a huge win like that for your V1, people are more willing to wait for the V2. So also prioritizing what your V1 ultimate outcome will be is important, because if it's something that's not hugely impactful, when they hear they're not going to get their dream outcome at the outset, it has to be a big enough win to where, okay, V2 is going to be in the next 6 months to a year. They're like, oh, we can live with that because the big pain point has been solved with V1. So all the other stuff is seen as like icing on top of the cake. Oh, you're on mute.
Yes, I was on mute. Always needs to happen once at least in a meeting. And so maybe a difficult question for you, Sarah. So we talk about like V1, V2 improvements. And then one of the biggest questions is obviously leadership knocking on your door and asking like, hey, Sarah, you've been doing all these changes, but what is the impact or what's the difference between the outcomes of V1 versus V2? Have you found a way to measure that properly in one way or another? Is it mostly quantitative or is it also qualitative, or how do you approach that to get buy-in from the whole organization that we need to get to this continuous improvement mindset?
I think it is both qualitative and quantitative. I think we have to use both to tell the story well. And so we do rely on both. I rely on both. And, you know, recently with a care flow that we've been working on, one of the things that is part of kind of like our pilot assessment is trying to gain some information on very specifically our members' confidence in understanding their own health. So we're using this kind of like as a proxy measure, right? To show us like, you know, we know that we might not see a change, let's say, in, you know, some sort of laboratory values for some time, but are we able to quantify in the short time that we have to kind of get on track and show our value here, that something's changing for the patient, right? That they're able to say, I understand my health better. I know what my next right step is in my healthcare journey, right? Trying to kind of get at some of those pieces so that we can show that we are on a journey with these patients and they're taking those next right steps. And hopefully then for our leadership, that shows like, hey, all indicators are pointing that we're moving people where we want them to move. So much of healthcare, especially where in the space that Crossover works mainly in primary care, is about behavioral change, right? And these are really hard things, especially I think in America, for us to tackle. And so trying to quantify some of that behavior change and what we're aimed at and how we're making a difference there is something that we've been really working hard to do in the interim.
Do you also have a similar approach, Adrienne, when it comes to like measuring the impact of a V1 versus measuring the impact of a V2, or do you have like an established framework or thing in place to really measure that in one way or another?
Yeah, I think that for both V1 and V2 is just like the North Star, and V2 is just getting us closer to that North Star. So the criteria shouldn't change drastically between V1 and V2. It's just has V2 gotten us closer to where we want to be from V1, and that's usually the goalpost, and just making sure you're not moving the goalpost every time, so it feels like you're never going to achieve the ultimate goal. But there may be tweaks around some of the success of V2. You're still looking to achieve the ultimate goal, what your North Star and why is, but it's more so these new features may have different impacts. So you're testing, are these features working as we intended? But still kind of like is V2 getting us closer to our ultimate goal?
Yeah, that makes sense. And then last question, because we need to wrap up, is one from the audience, which is addressed to both of you. So I will start with Sarah. Can you share an instance where a care flow transition or a care flow change didn't go as planned or was extremely difficult? And what lessons can we learn that could benefit others in a similar situation?
Yes, I have examples. I think that there's one that I can talk about from my time at Crossover, where we were implementing we do a lot of work around social determinants of health with our population, and really trying to get a full picture of the patients that we serve. And so we do a lot of surveying of our members and our patients. And the way in which the surveys rolled out was fine. That part was going okay with the patients. But we had a real big hiccup with the care flow part for our clinical care team, how they were going to receive this information, how they were going to ingest it and think through what they were learning with that information, how they were going to talk with the member or our patient about that information, and then what kinds of resources did they have, what kinds of tools in their tool bag did they have to turn around and help the member. And so I think that this care flow was like really good. Like it was like I don't know if half-baked is the right term, but it was kind of like, yeah, it was sort of there, but the care flow didn't go all the way, right? And so really what that V2 was all focused on is our number one client, the care team member, right? Helping that provider, helping that clinician know what to do with the information that we were giving them. Because we know in medicine, right, always we gather information to do something with the information. We don't just gather information to gather information. We always have to know what we're going to do. And so really V2 was all about shoring up that clinician experience and really arming them with the tools that they needed to take the next right action for each of those patients that they were encountering with that information they were encountering. So learned a lot in that process.
Do you have a similar experience or story, Adrienne, that you can share with the group that can have some valuable takeaways for them as of tomorrow, maybe?
Yeah, I think when we were iterating on building out a new scheduling system, The V1 was very successful, and then planning the V2, and then realizing that there was still a translation issue, I think, with some of the feedback around what the team meant versus how the engineering product team interpreted it, even though they were part of the same the different discussions. I think there was a divergence on, oh, we thought when you said this, you wanted to tweak it this way. They're like, no, it's the other way. Once again, very different languages. So V2 took a lot longer to actually get finalized, and it wasn't looking at a failure, but it was realizing that, you know, timelines are proposals. They're not, you know, hard and fast. And so your driving goal is, are we achieving this outcome? And I think I recently heard an interesting Planet Money podcast about Podcast Junkie around like why a lot of hospital systems still have pagers. And they talked about this framework around change management and adopting tech called RIP. It's like RHIP, risk, habits, identity, and power. And anytime you change anything in a system, you're addressing all of those different factors. And especially the power is a big one. You're changing the dynamic, especially a lot of tech. You're like, great, this opens up, we can communicate more freely with you, but that takes away power from the individual to manage the inflow of messaging and things like that. And so I think that's helpful to, as a lens, to think about some of the unintended consequences of some of the tech that's implemented. It's not just, does it work or not, or is the team happy or not? It's like, how does it change the day-to-day work and with how they get things done? And there was those intangibles that it's sometimes teams can articulate it, but sometimes they can't. But if you can kind of probe and get that information, that may give you more insight on the change management piece.
That was a nice story, and we'll definitely share that article in the follow-up email that we sent, because I also read it and it's a really good one. So time's up, unfortunately. What I have to share is obviously first thanking you, Adrienne and Sarah, for sharing all the knowledge. And then we also have our next panel or hangout, which is planned after the holidays, which will be with Sophia Guerra from Bessemer Venture Partners. And there we will focus on the financial and operational benchmarks for tech-enabled care organizations. So she recently published a report on the benchmarks, mostly on the financial part, and then with CareOps, we have some data on the operational benchmarks as well, and we will combine the data and have a discussion about that together with Sophia in January. So with that, I want to say happy holidays, Adrienne, Sarah, and everyone listening, and thank you so much for taking the time to meet with us today.
Awesome with you guys. Thank you.
Thanks so much.
Thank you. Bye-bye.
Bye.